Okay, thanks for joining us, everybody, today. I believe you got the kind of introduction from Rebecca about today's session, along with the discussion questions that went out today. So I won't give a lot of setup here. We're going to watch a video together. Hopefully our sound goes through to all of you okay, even though we're not hearing all of you. But we're going to watch a short video, about 18 minutes. It's from Dr. David Williams, who is with the Harvard Chan School of Public Health. He does a lot of research in the areas of trauma and the ways that racism, social economic status, and related factors impact trauma, and things to consider when putting in place solutions to address those factors. So it seems like a great kind of intersection of topical areas. We've had some previous presentations on racism and how that impacts historical and intergenerational trauma. I really appreciate this public health perspective on the topic. So let's watch that, and then we'll come back together, and Rebecca's going to put us into breakout groups to go through the discussion questions, and then for the last 10 or 15 minutes, we'll come back for some sharing out and general discussion.
All right.
Thank you so very much. It's really good to be here with you and to talk about an important area of work that we need to think about as we move forward in terms of addressing toxic stress. And I will talk about social and behavioral factors that play an important role in triggering toxic stress and that we have to address if we will be successful in the long term. And I will focus particularly in the time we have on the question of race and racial ethnic differences in toxic stress. So in the US context, before I talk about racial ethnic differences in toxic stress, I want us to realize that as a nation, we face a challenge. The US invests a lot in the healthcare domain, spends more money per person and more money absolutely than any other country in the world on medical care. But on any health outcome we look at, we tend to rank near the bottom of the industrialized world. I picked the example of infant mortality, where we ranked 11th in the world on infant mortality in 1960. But in 2009, we ranked 31st. So over time, we are losing ground, ranked behind other countries that we don't think of as our peer countries. And it's not just the minorities that are doing badly. I'll talk a lot about the minorities doing badly. But if white America were a country in 2009, it would rank 29th in the world on infant mortality. And black America would rank 49th, an example of the magnitude of the difference we have. And the differences that exist in infant mortality, death in the first year of life, persist throughout the life course. So there are very large racial differences in health. In fact, if you could, one way of thinking of the size of the racial differences in health, scholars have come up with this concept called excess deaths. And excess deaths for a particular population describes the number of individuals within that population who die each year that wouldn't die if there were no disparity in health. And in the United States, 96,800 black people die prematurely every year, who wouldn't die if the health of blacks was identical to the health of whites. That's 265 black people dying prematurely every day. Imagine a fully loaded jumbo jet taking off from Boston Logan Airport or any of America's largest airports. It took off and it crashed, 265 passengers and crew, and everyone died. And that happened today, and happened tomorrow, and happened every day next week, and happened every day next month, and every day for a year. That's what we're talking about when we say there are racial disparities in health in the United States. And think of what Congress would do to move heaven and earth to find out why there was such a massive loss of life. Well, we have a massive loss of life on such an unprecedented scale that we need to address, and that we really understand the importance of the foundation for good health in adulthood is laid in childhood, and that there is much that we can do to improve the health of all. One of the striking things about racial disparities in health in the US is that they still exist today. they have existed for a long time. So I'm showing you data on infant mortality in the US from 1950 to 2013. There's good news and bad news in the data. The good news is that the racial gap in health absolutely is narrower today than it was in 1950. The good news is that infant mortality rates have declined for both groups over time. Those are the only two racial groups in the US where we have data going back that far. However, the bad news is that in 2013, a black child born in the US is still 2.2 times more likely to die before his or her first birthday than a white child. And that's still a huge disparity that is unacceptable in our country. We know that socioeconomic status is a central determinant of variations in health, and it determines the distribution of all desirable resources in society, with health being one of them. And when I say socioeconomic status, I'm talking about variations by income, education, occupational status, or wealth. And just to illustrate, it's not only true for health, but every desirable resource. Here is SAT scores. For those who are not from the US, SAT is an important exam taken at the end of high school that determines where students can go to college, the quality of college they go to. And here's a relationship between SAT scores and household income in the 2014 national data of students who took the SAT score. And you see this straight graded relationship. Every higher level of household income is associated with higher SAT score, just illustrating the power of socioeconomic status shaping the resources that households have to provide a secure future for their children. Given this strong relationship between socioeconomic status and everything, including health, there's not a surprise that we have racial disparities in health, because there are large racial ethnic differences in socioeconomic status. This is a census report in 2014 looking at median household income in the United States, and I just have put it in a form that you just can't miss. For every dollar of income whites have, Asian households have $1.15. Asian households is a group heavily made up of immigrants who come to the United States with twice the level of college completion than whites do. So they have higher levels of income. It's not surprising given their high levels of education. However, that data is misleading if I look at just household income, because Asian households have more persons contributing to income on average than any other racial ethnic category here. So if we did a per capita household income measure, white households would have the highest level of per person income in the US. But the two disadvantaged groups that we want to focus on, Latinos have 70 cents in income for every dollar of income whites have, and blacks have 59 cents. What's intriguing about the 59 cents is exactly the racial gap between blacks and whites in 1978. Is identical to what it is in 2013. Most American thinks we have made much more progress than that. But even the data on income dramatically understate racial ethnic differences in economic resources, because income only tells us about the flow of resources into the household. It doesn't tell us anything about the resources, the reserves that we have to cushion shortfalls of income. And if we look at racial ethnic differences in wealth, again from a 2014 census report, for every dollar of wealth that whites have, blacks have 6 cents, and Latinos have 7 cents. That's the magnitude of the racial gap in wealth, and it's an illustration of why in the United States the minority poor are so much poorer than the white poor, although there are more poor whites than poor Latinos, and more poor whites than poor African Americans. The minority poor are much poorer because they basically have no economic cushion, one paycheck away from being homeless when there is no wealth, in fact. The data also suggests that although socioeconomic status, these inequalities drive the differences in health, it's not just socioeconomic status. There is something else about race that matters. And I'm illustrating that with national data for the United States on infant mortality. This is all births in a given year to mothers aged 20 or over by mothers' education. And what you can see, if we look here at 12 years of education, high school completion, less than 12 years high school completion, some college, and a college degree or more, we see the power of education. Every higher level of education is associated with lower infant mortality rates. That's exactly what we would want to see. But we also see something else that's quite striking. We see the towering excess risk for African Americans, with African Americans with a college degree still having rates of infant mortality that are about 3 times higher than other racial groups. And the also stunning example that the most advantaged black women with a college degree or more education, have a higher rate of infant mortality than white, Latino, and Asian women who are high school dropouts. So, and a powerful illustration of the fact there's something powerful about socioeconomic status that drives health, but there's something else about race that matters a lot. So we are looking at what might these distinctive social exposures be that drives this poorer health for racial ethnic populations. We know that part of it is higher levels of stress. You think of any psychosocial stress, minorities have higher levels. They not only have higher levels of stress, but they also have greater clustering of stress. We've done recent work looking at early childhood adversities, and for almost all of the early childhood adversities, Black and Hispanic kids are in fact much higher than whites, and there's also a huge gap by income level in the United States. So these stress is not randomly distributed in the population, and the higher levels and the greater clustering are factors that drive the poor health. In addition to that, there are distinctive social exposures. The distinctive social exposures I want to talk about is racism. Racism still persists in American society, and in fact, it's deeply embedded in American culture that has a powerful set of consequences. To illustrate that, some scientists have created a database of American culture. They've put in one data set the books, magazines, newspaper articles that an average college educated American would read over his or her lifetime. It allows us now to look at the association between pairs of words in American culture. So in this large database of 10 million words, when Black occurs in American culture, what word tends to most frequently co-occur with it? Poor, then violent, then religious, then lazy, then cheerful, then dangerous. So the ideas that Blacks are violent, lazy, and dangerous are deeply embedded in the American psyche, reflecting how frequently these associations have occurred in your lifetime as being a normal American. So when police officers overreact to young Black males, they're not being bad cops, they're being normal Americans reflecting the higher perceptions of violence and dangerousness that instantly occurs in a split second when they see someone of a certain skin color. Just for comparison, when white occurs in American culture, wealthy, progressive, conventional, stubborn, successful, educated. When female occurs, distant, warm, gentle, passive, male, dominant, leader, logical, strong. The size of the coefficient is a measure of the associative strength, how tightly clustered those particular associations are. These stereotypes are non-trivial, because there's a lot of research indicates that these negative stereotypes leads instinctively, without conscious awareness, to differential treatment. Another word for differential treatment is discrimination. And there's a growing body of research documenting that discrimination is one type of stressful life experience that has negative consequences on health. I'll illustrate that with a measure of discrimination that I developed many years ago called the Everyday Discrimination Scale. It is not a comprehensive measure of discrimination, but it captures those kinds of experiences that are patterned into the day-to-day experiences of individuals. Not big things like being stopped by the police or losing a job or not getting a promotion, but being treated with less courtesy than others and treated with less respect than others, and people acting as if you are not smart or if they are afraid of you. To illustrate the power of that work, I'm showing you the research of one researcher, Dr. Tenny Lewis, who was at Yale, now at Emory. And every line on this slide represents a different published scientific paper relating everyday discrimination to a particular health outcome. High levels of everyday discrimination in adults predict high levels of coronary artery calcification. That's the development of subclinical heart disease as measured in your artery. High levels of inflammation, high levels of blood pressure. Among pregnant women, high levels of low birth weight, high levels of cognitive decline in a sample of the elderly followed over time. In a community study, high levels of everyday discrimination, poorer sleep. High levels of discrimination in a sample of the elderly followed over time is an independent predictor of death. Elevated risk of mortality linked simply to the exposure to everyday discrimination. And finally, a study of black and white women. High levels of discrimination is literally making you fat. Not making you fat, but giving you the bad kind of fat, predicted high levels of visceral fat, unrelated to subcutaneous abdominal fat, which is the fat that is right under your skin, but the visceral fat is a deep fat between your internal organs, the type of abdominal fat that predicts higher rates of cardiovascular disease, diabetes, and so on. Among both black and white women, there was this association between everyday discrimination and health. And by the way, I should mention that although when I developed the scale, I was thinking about trying to understand minority health, we now know that all persons, this scale has been used in multiple countries, all persons report these types of experiences, and the attribution of why they experience it doesn't matter, so that although the levels of everyday discrimination are higher for whites than for blacks, whites who report everyday discrimination, the effects on health are in fact the same. Discrimination also predicts poorer outcomes for kids. It's a recent review by Naomi Priest. There are more than 100 published peer-reviewed papers looking at the effects of discrimination on kids and including on parents that have consequences for kids. In one study, racial discrimination reduced the black-white gap in preterm delivery and low birth weight. When you statistically adjusted for it, the black-white gap in preterm delivery and low birth weight was reduced to non-significant. So it's not only a significant predictor of outcomes, but it helps to explain the residual effect of race that we often find. Another study in Detroit that I did with some researchers, we found multiple factors contributing to maternal depression, like low education and food insecurity and financial stress and poor housing and lack of child care. All of these are factors that linked to maternal depression, but when everyday discrimination was added to the model, none of the other risk factors remained significant. Again, talking about disadvantaged minority women, the central role that these stresses play in their life. Another way in which racism still matters for health is the extent to which the historic legacy of racist policies still persist in residential segregation, the fact that individuals are clustered in particular places. There's nothing inherently negative about living next to someone of your own race. But in the history of the United States, segregation has not only produced living next to someone of your own race, but has produced the clustering of social ills in particular places. And research reveals that segregation affects health in multiple ways. Where you live determines your access to opportunities for education, the quality of education, your access to job opportunities, the quality of stresses in your housing and neighborhood environment, and violence exposure, and so on. This is a study from David Cutler and colleagues showing how powerful segregation is in the US context. Following a national sample of black and whites, Cutler, an economist at Harvard University, showed that if you could statistically eliminate segregation, you would completely erase black-white differences in America in income, education, and unemployment, and reduce black-white differences in single motherhoods by 2/3. What this means is that anything we do, if we will be effective in addressing the social determinants of health that drive the racial inequalities in health, have to address the question of place. We need some place-based strategies that seeks to improve the conditions in which people live, learn, work, and play to effectively address inequalities. How powerful is place? Two of America's most eminent sociologists said in the 171 cities in the US, there's not even one city where whites live under equal conditions to blacks, and that the worst urban context in which whites reside is considerably better than the average context of black communities. That's William Julius Wilson and Robert Sampson, two Harvard sociologists. So neighborhood, place, in multiple dimensions determines whether a community is healthy or unhealthy. And one of the things we want to do is shift communities from being unhealthy places to being healthy places, because we can think of all the dimensions by which place shapes opportunities to be healthy. So what can we do? What are we learning from the social and behavioral sciences? That effective solutions to reduce toxic stress and improve health need to be comprehensive. They need to start early They need to be place-based. They need to address the life course exposure to toxic stressors, because all of these things accumulate to produce the outcomes that we see in early childhood, but we also see in later life. I think there's much that we are learning in this area and much that we want to apply in the Center for Developing Child as we move forward to develop more effective strategies to address health and the inequalities that persist in health. Thank you.
Thanks, Rebecca. I'm hoping everybody could hear that. I'm not sure how this is going to work when we go into breakouts. If those of you that had sound issues will be able to communicate with the people in your breakout group. If you continue to struggle, maybe you could at least use the chat feature, or you could try calling in. But we're going to go into, I think, is it 3 or 4 breakouts, Rebecca?
Probably 4.
Okay.
I
We're going
think.
to 4 small groups. You should all have the discussion questions that were sent out. So we'll have about 15 minutes to discuss those as a group. There are 6 questions. We'll come back together. I would ask that you choose somebody to be a recorder and reporter for your team to share just some of the main takeaways that you had in each question. And in particular, I'm hoping we can spend most of our time together on the last 2 questions, talking about what lessons we've learned for our community and commitments that we're making. All right.
All right, bear with me while I get this all set up here. All right, I'm just going to do automatic assignment. So wherever you land, you land. Godspeed.
progress.
All right, I think everybody's back. Hopefully you had time to get through most of those questions. I know you were really pushing at the end to get through them. Rebecca, I should have gone with your second. I second how we were going to do the breakout. But anyway, we have 15 minutes left. I'd like to just ask the groups to share out things. So maybe we'll go on the different questions, and then at the end, I'd like everybody to have a chance to kind of weigh in. But I'm wondering if group one has any feedback they'd like to share on question number one about evidence that you've seen in terms of socioeconomic status kind of resulting in disparities.
I think that was us. We had a great discussion. Some of the, what was the question? How the socioeconomic status affects things. People noted that the food scarcity or food insecurity, the housing stressors, because we just don't have available housing, all those things have an impact on mental health. As far as requirement for education, for a higher education, which would enable a person to get a better paying job. Sometimes the requirements are very difficult for people of different racial backgrounds or socioeconomic status. For whatever reason, they just can't meet them, and that's a barrier right away. We would hope that those in leadership positions would abide by the law and hire people based on their qualifications, and all too often that does not happen. There's rather conscious or unconscious bias that enters into that. We have language barriers that can get in the way of people accessing resources. Single parents with limited income, awareness of resources, the whole internet challenge that we experienced during COVID made distance learning very, very difficult. Yeah.
Very good. If we have time, we'll circle back to these questions, but in the interest of time, I'll move on to question number two and ask group number two to comment on the roles of stereotypes and discrimination in determining health disparities. Megan, I think that was our group.
So we said that overall, we think that there is a huge role in discrimination in determining health disparities, and how it's so embedded in our culture and our psyche, and there's biases that are so deeply in all of our lives that life experiences have pretty much trained and taught us to be discriminatory and stereotype in pretty much all aspects of life.
Thanks, Megan. All right, group number three. How about question number three? What new insights did you gain about the intersection between race and toxic stress? Who's group three? Cammie, is that you?
We were group three. Beth was going to try her mic again. It's not working. Okay, so I'll go. So we just kind of discussed that, we as sometimes, don't. Oh, let me regroup here. We, as our privileged people, sometimes do not realize that normal activities may cause these stresses, like going into a grocery store or walking down the street, and that long term it can just snowball and get more impactful as we go. And just to be aware of that is kind of what we had discussed for that question.
Thanks, Cammie. All right, group number four. Given what Dr. Williams suggested about effective strategies, what strategies do you think we might consider prioritizing in Door County?
Where's Stacy go? Stacy, what was it that you said on this one? It was good, but I didn't write it down.
So I mentioned when you are with your medical or your mental health provider, I always do that little survey for like domestic violence, it would be nice if they could incorporate something like that into appointments and meetings to talk about those disparities and stressors. Because sometimes we don't even know that they are, that they're bothersome, but it would also give them an outlet to talk about it and be addressed in a medical or mental health place. We also said more mental health counseling, inclusivity in schools.
Yep. And Amanda typed that because her mic isn't working. So she typed in about more awareness of like domestic violence stuff, talking more about that, and also mental health, addressing mental health concerns. I think that was it.
All right. So each group, I believe, had a chance to report out on one question. I'd like to ask, in general, what any of you want to add about either strategies we might consider prioritizing for Door County, or what lessons we learned that we might want to apply to our community based on this information.
Oh, Amanda had mentioned inclusiveness. I think that's what she said. Like, tear down these racial barriers is what it is. I was sharing with the ladies that I've been told here in Door County, I've been living in Door County for 21 years, and I've been told several times to go back to my country. And I'm Puerto Rican, so I mean, I don't know what country I'm supposed to go to, but I like visiting Canada, but that's not my country. So like, you know, like, bring down the stereotypes and stop feeding into the nonsense. You know, just be more, you know, extend humanity, be kinder. I definitely believe that, but I think, yeah, definitely be more inclusive and embrace knowledge of other cultures, and because that can be very stressful. I was talking, sometimes I don't even want to speak my native tongue sometimes, because you're looking at people and they're already looking at you a little different because you look a little different, and then you open your mouth and another language comes out, and a lot of people automatically assume that you're talking about them, or, you know, why are you talking another language? It's like, it's nonsense. But it's things that, as a small community that we are, there's still a lot of those walls up, a lot of that stereotype, and a lot of it's like hidden, and people are like, no, I'm not racist. I have 2 black friends. If you can count how many black friends you have, yeah, that's a little racist. You know, like, so it's a little racial. There you go. But I just think, like, bringing down those cultural barriers and just including everybody, like, you know, America's supposed to be one big humongous melting pot. You know, if you're not Native American, you really weren't originally from here. So we all came here and brought our own little seasoning to the mix. So, you know, be more accepted of other people and considerate of other people's needs, I guess. Yeah, that's true. That's true.
For sharing your personal experience, Magda, that's really helpful. Carol put something in the chat saying one challenge
About affordable housing.
Lower paid workers have to compete with tourists for housing. Absolutely. Issue. Other thoughts on specific like strategies or lessons that we could kind of gain from this?
I think that we need to put more emphasis on training folks on how to be upstanders instead of bystanders, so that when we are out and about and we are seeing some not so appropriate behavior, that we become an upstander and interject in a non-aggressive but assertive way. I think that would be important for our community to try to learn that skill, and especially should be something taught in our schools. You know, a lot of times you'll hear, and it's true, you know, we aren't born with hate, we learn hate. And so starting with our earliest community members, our youngest ones, you know, is important, but also still needing to address it with the rest of the community as well. So that doesn't keep filtering, you know, flowing down the mountainside, if you will. Another thing is, I know something that I have personally experienced in my role is the language barrier can be a pretty big one as far as some of our community members accessing resources. So that I know that's something that we are trying to work on to increase the access to resources for some of our minority groups. So we just need to keep pushing on that as well.
Thanks, Rebecca. Yeah, I specifically mentioned in our group that I know that Rebecca, in her role as a community connector, has begun to do some kind of targeted outreach in pockets of the community that have higher numbers of minority populations, Spanish-speaking populations, just trying to build those bridges and connect people to resources. So I think anything we could do to kind of expand that across all program areas would be effective. I really liked his mention of needing to have place-based interventions. So even going to employers that we know employ more immigrants, for example, would be another thing.
I think one thing that we're already working on and will be continuing to prioritize for starting early is the Welcome Baby program.
Mm-hmm.
And that is an effort spearheaded by the partnership in collaboration with Family Services and other partners, so that parents, hopefully during the prenatal period, if not then during or after delivery, the postpartum period, they're screened and provided with appropriate services depending on what their needs are, so that hopefully we're getting people earlier and earlier than before they go to school and those things get picked up on.
Right, to address some of those family stressors early in life, that would be really critical. There any other, we have 2 minutes here, any other strategies anybody wants to mention, or if you are comfortable sharing what your personal commitment is based on this information, we'd love to hear that too. Kelly, I loved what your personal commitment was. I don't want to put you on the spot, but if you're comfortable sharing.
Sure. My commitment was kind of just to keep being open-minded to learn, and because I've realized the more trainings like this I do, the more access I make sure I have, the more repeated things are, the more I absorb it. And so I just appreciate get-togethers like this and continuing to learn, and so I commit to doing that.
Anyone else?
I would be interested in learning, following up on Rebecca said, some appropriate comments to make as an upstander rather than being a bystander. I don't know how to do that in a way because I get angry and I don't want to come. I also don't want to trigger someone to be violent towards me. I mean, this is a very touchy thing. And do we actually bring those up with our clients? I mean, is that appropriate during our time when we're trying to create a relationship? I don't probably think so, but the words, what are the words we should be using?
Yeah, I don't know. I mean, I know that there's lots of training on that topic. I wonder if there's a simple shareable resource that we could share in the meantime that might be helpful. I commit to doing some research on that, seeing what I can come up with. And if there's anything good out there, we'll share it. Okay. Beth put her commitment in the chat. She's going to copy Rebecca's. I like it. All right, well, we're up at 1 o'clock here. So thank you all for the discussion and the openness to ideas. Please let us know if you have topics you'd like for future Lunch and Learn. And we hope to see you all each month. We'll be together again the 4th Monday of August.
So much. Thank you. Bye-bye.